Hello, thank you so much for joining us. Thank you, Mark. Hi, good afternoon, evening, I should say. It's pitch black outside. Thank you, Brian, for joining us. Hi, Maggie. Hi, Norman. Oh, it's good to slightly see you. I can't really see your face. Good to see your name. Hi, Karen. Hi, Barb. Hi, Brian. Hi, Carol. Thank you so much for joining us. We really appreciate having you here. Hi, Murray. Good to see your name. Hi, everybody. Thank you. We're getting some people rolling in. It is 7 o'clock. So we are just going to get started. So good evening, everybody, and welcome to What is Neuropsychology, brought to you by NAMI Cook County North Suburban and Dr. Christina Blodgett, the founder and clinical director of Thomas Memory and Attention. I am Bree Hoekstra, the program director at NAMI Cook County North Suburban. NAMI, or the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization, providing public awareness, no-cost support, and education programs online and in person so that people and families affected by mental health conditions can build better lives. We are the lifeline to individuals and families who don't know what to expect in their difficult life journey. We offer classes and support groups and do a lot of local advocacy for mental health. Our programs are free of charge and open to those in our community service areas, but we don't turn anyone away who is in need. Our topic tonight will provide further education to better understand neuropsychology and the measurement of related constructs such as memory and attention. According to Science Direct, neuropsychology, defined broadly, is the study of correspondences between brain structure, mental function, and behavior. According to Cleveland Clinic, a neuropsychologist is an expert in how brain injuries and conditions affect your behavior, your mood, and your thinking skills, including general intellect, attention and concentration, processing speed, language skills, learning and memory abilities, reasoning and problem solving, visual spatial abilities, and mood and personality. They perform neuropsychological evaluations to assess how your brain and mind are working to suggest treatment plans. Some of the more common conditions neuropsychologists assess include concussions and TBI, or traumatic brain injury, epilepsy, brain cancer, stroke, neurodegenerative disorders like Alzheimer's disease, and movement disorders like Parkinson's disease. During tonight's webinar, you will learn when an evaluation is needed, how it is conducted, and how that will benefit a person with respect to treatment. We will leave plenty of time for Q&A at the end. If you would like to type your questions in the chat box during our conversation, please do. Tonight's guest speaker, Dr. Christina Blodgett, is the founder and clinical director at Thomas Memory and Attention, founded in honor of her grandmother's struggle with Alzheimer's disease. Dr. Blodgett earned her doctorate from the Illinois Institute of Technology and completed her fellowship in clinical neuropsychology at Loyola University Medical Center. Her clinical interests are in the correlation of neuropsychological data and neuroimaging results. Dr. Blodgett has 18 years of experience in this particular field. She was born and raised in a Northwest suburb, and she now resides there with her family. We are so thrilled to have her here tonight to further educate us on this ever important topic. I am honored to welcome our guest speaker tonight, Dr. Christina Blodgett.
Thank you, Bree. I appreciate that introduction and all that you do for NAMI. It's amazing.
Thank you. Thank you so much. I will see you soon.
Okay. Hi, everybody. Thank you so much for having me. As was mentioned, I am the clinical director and owner for Thompson Memory and Attention. We have offices in the Chicago area as well as in Minnesota. And I have a PowerPoint presentation, so I'm going to go ahead and open that up. So give me just one moment to share my screen and we'll get started. I'm also going to open up my chat function in case somebody has a question. Okay, so I went a little tongue in cheek here where I said that, is it a brain fart or is it memory loss? When is it a problem? So this tends to be a question that people have, because things happen, people get distracted, that sort of thing. So when is this a problem? So let's get into it. Oops. Okay, so just an outline for the presentation. What constitute changes in thinking? Like I said, when is it just a brain fart? You had a blip in your thinking, or when is this something bigger? What is neuropsychology? What is that practice? What does that entail? What is a neurocognitive disorder? We're going to talk a little bit about, I'll do a case example of a particular condition. And then we can get to how to strengthen your memory, which I will depend on timing. If I get to that, I have a lot of slides. So we can, I'll just keep an eye on the time. And feel free if you type in the chat here, hopefully it will pop up on my screen. Otherwise, I will definitely get to all your questions after we run through the slides. Okay, so when is it just kind of a blip in thinking versus something else? So here are some presenting symptoms that people might report. So losing common words, that feeling where the word's right there on the tip of your tongue, you know it, but you just can't get it. Misplacing items, you lost your keys, you lost your glasses, you lost your phone, that sort of thing. Maybe some difficulties navigating. Oh, do I make a right or a left here? Maybe feeling a little unorganized. Stacks are starting to grow on your dining room table that didn't used to be there. Maybe some distractibility. You went to make a sandwich in the kitchen and then you noticed there were dishes in the sink and then you started to wash the dishes and then you needed a towel. So you went into the laundry to get a towel and then you start doing the laundry and 2 hours later you make it back to the kitchen and there's a half-made sandwich there. Um, so here's the thing about that. These symptoms happen to everyone. In fact, half of them have happened to me today alone. And that just might be a matter of a busy schedule, or maybe you didn't get enough sleep last night, or one of a time change where now it looks like it's midnight outside when it's only 7 o'clock. All of those things can influence this too. So how do you make that determination of, should I be worried that I can't come up with the actor's name for the TV show that I'm watching? Or is this just kind of a normal process? So it is common to have changes in your thinking as we age. So we're going to talk. I was talking to Brie about this a little bit before we got on. There's neurodegenerative, like changes in your thinking, acquired changes in your thinking, and then there's neurodevelopmental. These are kind of differences in thinking that you've had all along. So this lecture gears a little bit towards neurodegenerative, but I am happy to answer questions too on neurodevelopmental. Know that there's two different categories. So one's acquired changes in your thinking, neurodegenerative, and they don't always degenerate over time, but that's the umbrella category that we use. And then one is neurodevelopmental. You were born like this, and this is how you've developed over time. So talking of changes over time, it is normal to have changes in your aging. So the memory of an 80-year-old is very, very different than the memory of an 18-year-old. And we don't expect an 80-year-old to have the same memory as an 18-year-old. And so we have all these different norms, statistics that we compare things to, and we can see what is normal for that person's age, or maybe that person's education comes into play. There are some things that are stable over time. Usually vocabulary is stable over time unless you have an acquired injury specific to that part of the brain. But vocabulary doesn't change as much, but things like processing speed do change quite a bit over the lifetime. You get slower as you age. So, for example, when an 18-year-old is driving a car, they have no wisdom behind what they're doing, right? Like they will make mistakes, so many mistakes, just because they've never been put in that situation before. But they have lightning fast processing speed. They are so fast. And then that does change over as we age over time. So those things start to decline, depending on what it is. But I usually say about your mid to late 30s is when you're going to start to see some, and you won't see changes, but there will be changes and kind of go from there. Although that's a very wide rule of thumb. It depends on the actual process. So when we're looking at these things and we're trying to determine if that word finding problem, that inability to come up with Brad Pitt's name when you're watching Thelma and Louise and you see him when he's a kid there, is that we want to ask the patient, the person who's experiencing this, is this a distinct change for them? Is this a difference in how they function? So let's take distractibility. There are some people who naturally are distractible, and that might be a neurodevelopmental condition. Again, that's a different lecture. The process for neuropsych is the same. So if they've always been distractible, them being distractible now doesn't count as a change. We're not looking at that as an acquired deficit. And a lot of folks, especially in certain age ranges, that was never assessed when they were kids. Now, kids have a lot of access to assessments and making those determinations if they do have difficulties with their attention or with reading or with anything. But there is a whole subset of us that never had access to those kind of assessments when they were young. So you want to make sure and ask, is this a distinct change in functioning? The other part we want to get into is, does it interfere with day-to-day activities? So we have what we call basic activities of daily living and instrumental activities of daily living. So basic is hygiene, grooming, bathing, get up and going type of things. Instrumental is more complex. And this is where there's a lot of gray area. If someone may be just fine getting up and going, they can bathe themselves, of course, they can go to the bathroom, that sort of thing. But if you ask them to, I was going to say balance your checkbook, but most people do online banking these days. That's showing my age a little bit there with balancing the checkbook, or so analyzing the finances, or maybe it's work, and work is more difficult for them. They can't get through. They're getting negative performance evaluations at work, that sort of thing. One thing I always ask about is medications. Are they remembering their medications? Are they taking it accurately? Is that a change? That's a big one, and can be really impactful in day-to-day functioning. So the onset of these changes can be abrupt or gradual. So abrupt, maybe there was a motor vehicle accident and there was a head injury with it. That's an abrupt change. But some folks, this changes over time. And maybe it's because they have different chronic medical conditions that they're grappling with, and they're trying to figure out how much is this influenced by that. So there's all these different factors to consider. So what's interesting is that a lot of people don't report this to their medical providers. In fact, only about 10% of people who have been experiencing changes in their thinking bring it up at a doctor's visit. This data is a little bit old. This is from 2006. So this might have changed a little bit as this is more in the common culture and people have more awareness on it. But I think it's still very true that a lot of people do not report these things despite going in for a doctor's visit. Oftentimes that doctor's visit's very quick and you're focused on a myriad of physical symptoms, and some of those changes in thinking aren't addressed, or again, it's hard for primary care physicians, especially to know what that gray area is. They may just say, you're busy. You got a lot going on. Your depression's acting up. And so there's all these ways to blame it or punt it away when it really might warrant a little bit further investigation. So a lot of times they just kind of linger, and then it only comes to a head when something bad happens. You get fired from your job. start a fire because you left the gas burning on the stove. Something where something bad happens. And so that's kind of one of the great parts about NAMI having me come and present this to you, is that it raises that awareness, because we don't want it to ever get to that point where a crisis happens. Let's go ahead, and if there is something that's going on, let's get it checked out before the crisis happens. Okay, so let's get into what is neuropsychology. It's a big, long word, and we say things about, understanding the brain behavior relationship. What does that mean? So when people think of psychology, most of the time they are thinking about treatment. They're thinking about behavioral treatment. You're going in and you're talking to a psychologist, and you're looking at the behaviors that are going on. You're looking at processing the emotions that are connected with those behaviors, or processing the thinking patterns that are connected with those emotions. But neuropsychology isn't treatment. Neuropsychology is diagnostics. So in the world of medicine, you have interventions and you have diagnostics. So we're on the diagnostic side, we're on the investigation side. So just like if you wonder if you broke your arm, you would go have an x-ray. That x-ray is a diagnostic procedure. So for neuropsychology, you're having some memory loss, you would have a neuropsychological evaluation. That's an investigative procedure, a diagnostic procedure. And so this is kind of, again, a little funny here. We got Homer Simpson, and how his brain is versus what are the functions of that brain. So, but in a more serious matter, we know where what we call typical localization of functions are. So we know where semantic language is from phonetic language, two different types of language. We know where personality is housed in the brain. We know where organization is housed in the brain. We know where consolidating new memories is housed in the brain. These are all in specific locations when you have typical localization. Not everybody has typical localization, but most people have typical localization. So what happens when you have somebody with a brain tumor, like this gentleman here? This is an actual patient of mine who had a brain tumor in his left parietal lobe. And how is that going to impact things? It is an MRI, so it's flipped. So right is left and left is right. So now that he has this huge tumor that is pushing on the brain tissue and displacing things, how does this come out? How does this change his functioning? Always a caveat there. So our understanding of the brain is still in its infancy. You think that we know all about it, but we're just learning every single day. Back in the day, we didn't have these kind of sensitive neuroimaging techniques, that sort of thing. And we learned by people who have had terrible brain injuries. And we learned by somebody who had a railroad spike that went up through their frontal lobe, and we watched their behavior, and we learned how those behaviors are associated with the frontal lobe, that sort of thing. But besides the localization of functioning, this goes here and this goes here and this goes here, there is everything's connected. So even though maybe there is a deficit or injury or an occlusion in the occipital lobe, it can impact the frontal lobe, two different areas of the brain, simply by the connections that run between those two areas of the brain. So when we talk about localization, it's a very simplistic way of looking at the brain. The brain is much more complex than that. Don't let anyone ever tell you, well, that's not right. That's not how that happens, because there's millions of connections that are going on there that we're still very much learning about. So neuropsychological profiles. So what we're going to do, and I'll explain what a neuropsychological evaluation is, but basically what we're getting is patterns of function. Okay, so when we're looking at those different areas of thinking, we're going to put jigsaw pieces of data together. And once we put all those pieces together, they make a picture, like that, like just like doing a puzzle would. You take this little piece of data and you connect it with this little piece of data and you put it all together, and then you could a picture of what's going on. We call those profiles, neuropsychological profiles. And those profiles match up with different conditions. They match up with an Alzheimer's disease process. They would match up with a Parkinson's disease process. They would match up with an attention deficit hyperactivity process. So as we collect these data points, we create a profile and we see if those profiles match up with known profiles. And there's some variability in it. For those of you who have certain medical conditions, you know that there's very different. So let's even take depression, for example. Somebody who is having a vegetative depression is very different from somebody who's having a reactive depression. In a vegetative depression, there's a lack of inertia, there's a lack of energy, there's a lack of motivation. In a reactive depression, there is sadness and there's hurt and there's over crying and all these things. They look totally different, right? But they still fall under that umbrella of depression. So again, we have these profiles, but you don't have to tick every single box in this profile for it to fall on, to match up with one of these conditions. Okay, so how do we test this? So first you're gonna come in and we'll talk a little bit about that, but you have a very complete interview. So interview provides context to what's going on. I need to know all about what symptoms you're experiencing. I need to know from maybe somebody you know really well, maybe a spouse or a good friend, somebody, what they're seeing. They're like, oh, Johnny's not the same as he used to be, that sort of thing. So we want to hear all about those symptoms. But then I need to know all about your history too. I need to know about medical conditions that are going on. And I need to know about your psychiatric history. I need to know about all your social history. How many years of schooling have you gone through? What's going on with your living situation? All of those things are collected. So we do a really thorough interview. The nice part about neuropsychology is we are allowed, it's laborious. It is long. I will give that to you. It is a long process, but it allows for us to give you the time that some of your other doctors don't have to give you. The general medical community relies on these short interviews, typically about 6 minutes long, to gather this information. Our interviews are typically an hour long, and we collect tons of data on top of that for just the interview component of it. After the interview, then we have a good idea. We have some hypotheses as to what's going on. Okay, this person's reporting memory loss, and it's been gradual over time, and it's getting worse, and they're losing things more often. So now we're going to put together a test battery that assesses all those different areas of thinking to look at those symptoms that were reported. So it is both important to rule in diagnoses and as important to rule out diagnoses. We get all the time. So again, this little neurodevelopmental versus neurodegenerative, the overlap in symptoms between ADHD, bipolar, and borderline personality disorder is they're so similar. And so now we have to tease these things apart. So we have to know, are you having one of those things, none of those things, all three of those things? What's the combo going on here? So how we test this is usually you're one-on-one with an examiner. So this is a very old picture from when this is not me, but obviously this was a friend of mine at Loyola. So those were the lovely blue coats we used to use there. But you're testing in a situation where it's a series of shorter tests typically, and they're brain teaser type of tests. We are going to look at all those different areas of thinking. So we're looking at, first we have to know where your general functioning is. What's your intellectual potential? Because it makes a difference if your starting point or your baseline is at the 25th percentile or the 90th percentile. Because now that becomes your benchmark and your standard to compare things to. For those of you that are familiar with Alzheimer's research, there was a huge project, and it's been going on for a couple of decades. And fortunately, what they determined maybe about 5, 7 years ago, and they're like, why do we have such amazing data and we're not getting anything from it? And what was happening is they were including everybody in that data set. And what they would do is they would over pathologize people of lower intelligence, meaning they would diagnose them with conditions way more often, even when that condition wasn't actually going on, just because they had lower test scores. And they would under pathologize people of higher intelligence, meaning that somebody who was actually experiencing a condition was not getting diagnosed because they had higher test scores because their baseline functioning was higher. And so once they figured out, like, oh my gosh, we don't have this equation quite right, they were able to eliminate some of that static at the upper and lower ends of the normal curve, to get a more pure data set and really start to make some headway. And you'll see lecanemab was just approved for emergency use in January for Alzheimer's disease. So that'll be interesting to see. And it reverses some of the effects. So it'll be interesting to see how that plays out. But sorry, that's a tangent. It's, like I said, is it a problem? Is it a brain fart, or is it an actual problem? So when we're looking at intellectual functioning, we want to look at all several different constructs within that. So we look at verbal abilities, we look at nonverbal abilities, we look at working memory, and we look at processing speed. Now, if you have some neurodevelopmental problems in the domain of attention, we can actually then subtract out the working memory and processing speed indices to then get a more true general abilities function. But we have tons and tons of statistics that we're going to run between these different sets of data. And we're looking for discrepancies between things. So most people, if you're neurotypical, are going to have, if you're at the 50th percentile in one, you'll be at the 50th percentile in the other, and you'll be at the 50th percentile across the board. And what we're doing now is we're starting to look for things that don't line up with that baseline. So major cognitive domains that we're looking at, we're always looking at language skills. We're looking at receptive language, expressive language. We're going to see how quick your fluency is, how quickly you can come up with words. We're going to see if there's word substitutions in there. Are you having difficulties understanding things? Attention is such a complex umbrella category, and it's usually on a spectrum with another area called executive functions, which I'll get to in a minute here. But there's so much that falls under attention. The big one that people are interested in finding about is sustained attention. Can I stay on something and focus on something for an extended period of time, even if that's a monotonous task? But there's basic auditory attention. Can you pay attention to what I'm saying? Can you hold information in your mind and work with it while it's on kind of your desktop in your mind? So there's a lot of different areas in there. Processing speed is also part of attention. Some of you may or may not have heard of a term called sluggish cognitive tempo, and it is an unofficial subtype of ADHD that's very specific to processing speed, but it falls under that domain of attention. Memory is a complex construct. You have to take in the information. You have to then consolidate that information and put it into your memory stores. And later you have to retrieve that information. And maybe that information's up there, but you just can't access it, right? But could you recognize it? Were you talking about Sally going to the dentist? Oh yeah, that's what it was. I remember what we were talking about now. That's recognition. So that information was in there, it just wasn't filed correctly. So there's several components to memory, and obviously attention has an impact on that as well. So visual spatial skills, the underappreciated domain of brain function. This is how your brain interprets what you see. So it doesn't have to do with your actual vision, but it has to do with your processing of visual information. What's your perception of where things are at? How about construction? Can you put together things? That sort of things, all nonverbal. And it wasn't until maybe the 1950s or 1960s that this really got some traction. Before that, things were so verbal, and people would underestimate someone's abilities, especially if they had a language disorder. Let's say from a neurodevelopmental standpoint, they had a language disorder, a language delay, and they would then labeled as having intellectual dysfunction when they didn't, because their nonverbal abilities were fine. They just happened to have a language issue. So this really picked up some traction, and there's some pretty cool tests with visual spatial functioning. Executive functioning, I mentioned that earlier. It is sometimes considered to be on a continuum with attention, but executive functioning has to do with higher order thinking, planning, organization. Can you execute the problem that you solved? Can you put it together in application? Though multitasking, set shifting, those types of mental flexibility, that higher order of functioning that happens. Now, we always want to look at emotional functioning as well as personality functioning. We're going to look at externalizing behaviors, as far as anger or aggression goes. We're going to look at internalizing behaviors, depression, anxiousness. We're going to look at interpersonal relationships. We're going to look at all of those different functionings. This is very important. And I'll tell a little story. I was on internship, and I was real nerdy with neurology and neuroimaging and all of that. And I had I had a supervisor. His name was Harvey, and he wore sweaters with the leather patches on the elbow, and he was just a quintessential psychologist and very kind and very caring. I'm like, Harvey, why are we doing all this testing on emotions? I'm a neuropsychologist. I want to know about the neurological functioning. And he turned to me, he's like, Christy, if we don't do it, no one will. And that in my tracks stopped me. And I realized that this is something that a lot of people are never assessed in, or they are dismissed in this area, or they're punted immediately to a different subspecialty. So we always make sure that we take care of the emotional and personality side of the assessment as well, because it's part of who you are. Okay, so we're gonna do a little bit of a test here. You can play along if you want. You don't have to. If you have a pen and paper near you, you might want to grab it, but don't use it until I get to the construction part of it. The first part, we're going to do a little memory test. So don't use the pen and paper for this part. I am going to read a word list to you. After I read that word list to you, I want you to say that word list back to me. So I'll go through it, and then I'll have you guys do it. Obviously, the sound's not on, so you're going to just have to kind of gauge yourself on this. Okay, here is your word list. Leg, cotton, school, lily, blue. Okay, go ahead and tell me all the words that you can recall from that word list. So you're going to have to do that yourself as teleconference format here. So that's one of the ways. So this is measuring encoding. How much can your brain take in? What's the capacity for it to take information in? Now, we usually measure that we have usually repetition with the word list, or we'll do context with maybe a short story. Okay, next, we're going to look at attention. So the first thing we're going to do is what I'm going to say is a series of numbers. I want you to repeat those numbers back to me. Okay, I'll say the numbers. You're going to have to repeat them back to yourself. 7, 5, 4, 8, 1. Go ahead. Okay, so that's basic auditory attention, is to be able to say that series of numbers back. So it's just kind of repeating that sound back to you. Next, I'm gonna say a series of numbers. I want you to say those numbers backwards. So I'll say the series of numbers, you say the series backwards to me. Here's the numbers. 3, 4, 2. Now you say them backwards. So it's a little bit more difficult because you're now having to manipulate that information in your mind. So basic auditory attention, complex auditory attention. So those are just a couple of the short, easy ways that we assess some of that. And we never just use one data point. We always get multiple data points. Okay, now's the pen and paper part. So go ahead, and we've got this cube up on the screen. Go ahead and copy that cube right on your paper. Try to make your cube look as much like the original as possible. I'll give you a few seconds to give that a go. So as you're doing this, you can see that sometimes this can be, you think, oh, it's just a cube, I'm going to do it. And it turns out to be a little bit tougher than you think it's going to be. So it's hard for me to gauge where you're at with the cube. I'm going to move on, but that's one of the construction tasks that we would use for visual spatial skills. All right, now we're back to the memory. Okay, tell me all the words that you can think about, or all those words that you can recall from the word list we went over just a few minutes ago. So go ahead and see how many you can recall. I'll give yourself maybe write them down. Okay, so that is called free recall or retrieval. So retrieving the information is actually a product of your frontal lobe, whereas consolidating that information, taking it in and putting it into your long-term memory is a product of your medial temporal lobe. So two different areas. So as people are doing these different tasks, I'm thinking about how this part of their brain is working and how the middle part of their brain is working. So now, okay, so let's say there were 5 words originally. Maybe you got 3 of the 5 words. Now I'm going to give you a prompt, and that prompt is going to tell me whether or not that information is in there, or whether it's gone forever, or somewhere in the in-between. So I'm going to give you some clues, some prompts. So one of the words was a part of the body. It was leg. One of the words was a type of fabric. Was it cotton, denim, or velvet? So I'd often give people choices, and then they'd say, oh yeah, it was cotton. That's right. One of the words was a type of building. Was it hospital, school, or church? And maybe it's gone. Maybe you never encoded it in the first place. It was school. Was it was a type of flower. Was it rose, tulip, or lily? It was lily. So again, two different. There's a prompt there, and then you can actually pick it out and recognize it when given to you. And last one was a color. Was it red, blue, or green? And it was blue. So there's several different ways that we're assessing memory. We're assessing it by how much can you encode, how much can you freely recall, how much can you recall with a prompt, how much can you recognize. So several different functions, and all represent different areas of the brain. Okay, this one's a tough one. I'm going to actually put my timer on for this, and I want you. And so for this one, you don't have to write them down. You just want to count them, because the writing down will slow you. I'm going to put a minute on the stopwatch here, and I want you to come up with as many words that begin with the letter F as you can. Couple of rules. I don't want you to give me any proper nouns. So no names of people, no names of places, nothing that would have a capital F in front of it. And I don't want you to give me any numbers. And don't give me the same word with different endings. Okay, I'm gonna put a minute on the stopwatch. I want you just to count how many you get in a minute's time. Go ahead and tell me all the F words that you can think of. And obviously you're not telling me because we're doing this virtually. But again, come up with these as you're thinking it, count on your hand, count on slash marks on your paper for the different F words you can think of. So one of the things I'm looking for in this task is if people are making, repeating themselves in it. I am looking for loss of set. Maybe they start with F words, but then they move on to S words and they don't catch themselves and they keep on going with that. I am looking for when they just kind of, I always prompt them if they kind of give up and like, I'm done. I'm going to say, no, it's only a minute's worth of time. I want you to keep on going. I'm talking through this, so please know that normally I wouldn't be talking through it. You'd have a more pure number there. Okay, stop there. So when I look at this, I have reams of data. It's not reams anymore. Everything's on the computer. It used to be reams of paper. But then I'm going to look at how many you do, and then I'm going to chart that on a normal curve. But from a very basic cutoff, most people, what the cutoff would be 11. Could you get 11 F words in a minute's time? And again, not indicating if you got less than 11 that there's a problem. That's just one data point. That's kind of one way that we measure things. And again, this is not a traditional paradigm that we're doing it where you're counting. It would be an examiner administering it to you. But it's harder than you think. For those of you that tried it, you think you're like, oh, I can come up with F words all day. And then you get to about 30 seconds and you're like, whoa, I can't think of any more. Okay, so this one's more in abstract reasoning. So this is kind of higher level thinking, and the questions kind of get harder as they go. So for example, I want you to tell me how these two things are alike, how they're similar. So how are a tiger and a mouse alike? So the correct answer would be they're both animals. But a lower level of answer would be they both have feet. Now, both are true, but one is kind of taking that to a higher level category, and one is more of a concrete level. How is a car and a train alike? So again, the answer that we're looking for, the higher level answer, is transportation. The lower level would be then taking a component of that, and then they might say, oh, they both have wheels. So that would be, we're looking for that higher level of how they're alike. How are a clock and a ruler alike? This one's a little bit harder. And what we're looking for is measurement. They both measure things. A lot of times people will say they both have numbers. Again, both are right, just one is a higher level of conceptualization. Okay, so now we've done all this testing. All of these tests, by the way, those tests that I just gave you aren't actual tests because tests are it falls under actual trade secret law, because attorneys ask me about this stuff all the time. They want access to it, and I'm like, you can't have access to my tests. But if lawyers knew about them, then you guys would ruin it for us. So those tests that you just did were kind of examples, or kind of from the hip spinoffs from tests. So the tests that we have are all administered in a very standard way. And the reason why they're administered in the same way to all the people is now we're going to look at your score on it, and we're going to compare that score to all of so there's tons and tons of data of what a quote unquote normal score would be on that. So you see here we have the normal curve where most of the people fall in the middle in the average range. And then that curve goes out to the each end, with less of a percentage falling in that above average or superior range, and then a small percentage of people falling in that impaired or borderline impaired range. But most of the people will fall in the average range. So we're going to look at how you performed on these tasks. We're going to take a look at what we call pre-morbid intellectual abilities. Pre-morbid sounds like a weird word, but it just means what your functioning was before you acquired your symptoms. And so a lot of times we have to guess at that. Not many people have testing, but here is the great part is, like we said earlier, vocabulary is one of those things that sticks with us over time, even when we acquire brain dysregulation, barring that it didn't happen to a language part of the brain. And so we can get a good gauge of where those premorbid abilities were. And so now what we do is we map out where your functioning is. So for this particular person, their premorbid functioning was average, and visual spatial skills are really great. They're at the average or high average range. Memory and language skills are in the average range, just where they're supposed to be. But this person, for both attention and executive functioning, they're falling in this is about the 10th percentile here. So they're performing differently in those areas than where they should be functioning. So this is what we call a discrepancy analysis. And so we're looking at whatever that intellectual potential is compared to that deficit. What is the difference between intellectual potential and deficit? And so this is, remember when I was talking earlier about that under pathologizing high level people and over pathologizing lower level people? So if this intellectual potential is down here on the curve, lower on the curve, even though this person's falling in the average range, now this person is performing at about the 7th percentile here. And so that's going to look like a deficit to them. And it is a deficit in this scenario. But then you have somebody like this who maybe has an intellectual potential at the 90th percentile, and their deficit is falling at the 25th percentile, which is still considered average. And someone might come along and say, well, they're not impaired, they're average in that area, but it's a change for them. So we need to look at that discrepancy analysis. So in fact, when you look at these, for the person who was maybe, I mean, they're average, they're totally normal, like there's nothing wrong with that. But the difference between their intellectual potential and their deficit is actually smaller than the difference between this one, where they were at the higher end of the curve. And this person may not qualify for different resources or benefits because they're saying, oh, well, they still fall in the average range, so they're not impaired, even though that their acquired deficit is far greater than the deficit in this case over here. So this discrepancy analysis is really important to do, and it's very specific to neuropsychology because a lot of other disciplines do screeners out there, and they will not even address a deficit unless it's below the 10th percentile, and they never take into account baseline functioning. But neuropsychology does, and we always do a discrepancy analysis. So after I do this analysis, after I put all these data points together and I get a real clear picture of how the brain is functioning based on those different areas, those different cognitive domains, I put together a very thorough report with all that background information, all those reported symptoms, all the medical and social histories. And then I put the results in there. The results are full of technical jargon, and things are really like, that's where we use all of our $3 words that we learned in grad school, because if you were to have an evaluation down the road by a different neuropsychologist, I want that person to know exactly what we found. So know that the results section is not really written for the patient, it's written for another neuropsychologist. But the part that's really important to you as the patient is going to be the summary, the impressions, and the recommendations. So this is where we pull it all together. Okay, here's your cognitive profile. Here's what it matches up with. Here's what you can do about it. So the summary, impressions, and recommendations are that's the part for you. Okay, so let's talk about a neurocognitive disorder. I am talking a lot, so I'm just going to try to keep an eye on the time here. So a neurocognitive disorder, we have two categories. We have major and mild. And these are umbrella categories, and they're pretty, the criteria to meet to qualify for a major or mild neurocognitive disorders is pretty easy to do. So, but we'll go into then, the important part is then to determine the etiology or the cause of that neurocognitive disorder. Major neurocognitive disorder just means that they're having a significant decline in function, so much so that it's negatively impacting their day-to-day functioning. So we've got a significant decline in functioning, a substantial impairment, and it interferes with daily activities. Mild neurocognitive disorder just means that there's been a mild change in functioning, and the functions, the cognitive deficits, the cognitive problems that they're experiencing do not interfere with day-to-day activities. Okay, so mild and major. So a lot of people ask, I don't want to get into it because it's gonna open up Pandora's box, but for those of you who want to know, so major neurocognitive disorder is akin to dementia, right? So that's the old term that we'd use for dementia. You're having significant changes in your functioning, so much so that they're impacting your daily activities. Mild neurocognitive disorder is what we now use for, we used to have a category called MCI, or mild cognitive impairment. We now use this. However, those categories people associate with disorders that are progressive in nature. So when you think of dementia, you're thinking dementia of the Alzheimer's type, right? It's progressive. But neurocognitive disorders can be due to a whole host of things that are going on. So, for example, we have neurodegenerative, right? So here, a chronic condition of neurodegenerative, I don't have table 2 here, is going to be Alzheimer's disease, or diffuse Lewy body disease, or frontal temporal dementia. But an acute condition can be delirium. So somebody can be delirious because they went under anesthesia for a surgery, and they came out and they were super confused afterwards. Or maybe they had a UTI, a urinary tract infection, and that infection made them super confused. And when the infection clears up, oh, well, so I've got infection next to it. That can change, then it clears up. So, right, it doesn't stay, it's acute. So there's different things that we look for. So some of these conditions that are degenerative in nature, that do progress over time, get worse over time. So degenerative is it's getting worse over time. But it could be due to an infection, or some sort of inflammation in the body, or neoplastic, that's going to be like brain tumor. Nutritional. So, I mean, you could be just off on your B12, and somebody fixes the B12. So that's why we always want to make sure there's a very good medical assessment. We want to make sure labs have been drawn. We want to include all those. Psychiatric, is this person in an acute psychotic episode? Well, that's going to make a total difference versus somebody who maybe has a chronic severe psychiatric illness, and they're in such a severe depression, and they've been in that episode for some time. Toxic, is this a product of drug interactions? Traumatic, so an acute, so people can get their bell rung and they're fine after a couple of minutes, or people can have traumatic brain injuries that stay with them. And then, as the big talk is in contact sports, chronic traumatic encephalopathy, or CTE for the football players, or hockey players, or again, any kind of contact sport. Vascular. So people, you would be surprised how quickly after somebody has a stroke, the improvement that they make in those first few days is crazy. Like, they call me in to do assessments right after somebody's had a stroke. I'm like, no, they'll be a totally different person in a week's time. So there's no point in doing the assessment. Maybe just a brief one right then. but it's not going to really give you a good concept of what it's going to be like over time. So there's all these different causes. So we would have major or mild neurocognitive disorder due to, and then we'd look at all of these different things here. So it's always due to. So this is when you're getting the impressions. You want to know what it's due to. You know, I'm having these changes. Is it because I have possible Alzheimer's disease? Is it because my bipolar is not being well controlled and is now negatively impacting my thinking? Again, we want to, as we're kind of thinking about these differential diagnoses, we're gonna look at onset and progression, the age of onset, the medical history. Again, we want to look at that neurodevelopmental history. So if you have had ADHD your whole life, maybe it was undiagnosed, and now I'm looking at this and you're maybe you're, you know, in your 60s and you're having attention and concentration problems. Well, I'm going to say, oh, I wonder if it's vascular, you know, because attention problems are very common in vascular conditions, cerebral vascular conditions. But I would be wrong in doing that if I didn't conduct a history to find out that you maybe had attention problems your whole life. Maybe there was a specific learning disorder. Maybe you were dyslexic. Maybe you were diagnosed or were not diagnosed with autism or an autism spectrum disorder somewhere along the line. So all of that has to be included in there or diagnosed along with it. So again, as I mentioned, we're kind of focused on neurodegenerative, but there is neurodevelopmental in there too. Okay, so my case example is Alzheimer's disease here. So I'm just going to run through this super quick just because it's a common question that I get. But so again, the major or mild neurocognitive disorders, just that umbrella category of whether or not you're having changes in your thinking, so much so that it impacts your day-to-day functioning. For Alzheimer's disease, your memory is impacted far and away worse than your other cognitive domains. So remember when I said, you know, if you're at the 50th percentile for language, you should be at the 50th percentile for visual, spatial skills, this, that, and the other. So in Alzheimer's disease, you would kind of see that it's not a totally flat curve, but you'll see, 50th percentile for this, 50th percentile for this, 50th percentile for this. Memory, bang, second percentile. It is night and day. That memory function is much worse, far and away worse than the other areas. It has an insidious onset and gradual progression, which means that it kind of sneaks up on you. Yeah, that's where you get this. That's why I have this, you know, is it kind of, you know, are you just having a moment or is this really a problem? Is because people have moments, right? Your memory is changing across the lifespan and then all of a sudden it sneaks up on you and you're realizing that your loved one is not remembering things like they used to, and it's getting worse over time. There is average age of diagnosis is 75, and more so as people age. So there's a controversial theory out there is that if we all live long enough, we would all develop Alzheimer's disease. And as people are living longer, we're seeing more and more diagnoses of it, or more and more incidents of the condition. That is a very controversial statement because we have super agers, people who never have these changes. So we're trying to study them too to figure that out. The older the onset of the memory problems, the slower the course, which is great. I'll have somebody who's 85 who is just in the very beginning stages. And I'm like, this is a 14, 15, 20-year process here. So not to be morbid, but it's not going to be their demise. The earlier onset is it's quite rare. So people think that it's an early onset, but early onset is rare. It doesn't happen very often, but does have more of that familial component to it. If it's happening when you're older, it could just be part of, again, controversial normal aging. It's not normal aging, but it could be, it's more sporadic. It's not related to genetics. APOE allele 4 is the genetic coding. If you have that genetic coding on both chromosomes, you are more likely to develop Alzheimer's disease, and it's more likely to be a quicker course. That said, just because you have that allele. So allele 3, so the E4 is the one that's puts you at risk. Allele 3 is the most common allele of this coding, genetic coding. It doesn't mean that you're going to have it. I haven't done my research on it, but I think it's one of the Hemsworth brothers has it. And now he's like thinks he's going to have Alzheimer's disease, but it's not how it works. It's just a risk factor if you do have it. There's something called cognitive reserve. Oh, and it's 8 o'clock. So that means that if somebody has their smart cookie, they're not going to have that kind of gradual decline. They'll actually decline a little bit and have a plateau, and then they'll kind of fall off a cliff. So it's a little bit of a harder process to determine because they hit that plateau and you're like, oh, they're going to be okay. And then it just gets past that point that they can't compensate. Okay, I have some, let me see here. So you can see the atrophy of the brain. So down here, you can see here's the normal brain in picture B here. And in picture A, you can see it's just shrinking, the incredible shrinking brain. Don't worry about the neuroimaging. It's not really reliable anyway. Neuropsych testing is way more accurate for diagnosing Alzheimer's disease. Okay. And we hit strengthen your memory, but we will save that for another rainy day. And I don't want to keep you too long here. But it's a great time for questions and answers. I'm happy to answer anything they might have. So I'm going to open up the Q&A here, and then I'll open up the chat function too, because they're two different boxes. Okay, so the first one is, I'm interested in knowing if this information is the same with someone that may speak 2 or 3 languages with focus. Okay, so 2 or 3 languages. Here's the very cool information about language, is that early in their developmental testing, they actually have lower test scores than other people who are monolingual. But as they age, their test scores then far exceed monolingual folks for the polylingual folks. So that is a great exercise for the brain. It's great for the brain to engage in. It really keeps that strong. What's interesting is that when your language starts to be impacted later on, you will start to lose words of the language that you've known the shortest amount of time. So you'll be able to recall it in your primary tongue, but if French is your secondary tongue, you'll lose that word sooner than if English is your primary tongue. So language is very cool, but it's a great exercise for the brain. Can statins affect memory? Okay, so the research on it used to be yes, and now the research on it is no. So it is, I think it's an area of investigation. So the problem with statins is we don't have a really great concept of the biological mechanisms behind them. So also, I have to, I'm a PhD, not an MD, so take everything I say about medications with a grain of salt. It's technically outside my purview. So there is some older research that would say yes. The newer research refutes that and says that statins do not impact memory. I'm going to open up. Okay, there we go. I'm going to move that there. Okay. Any other questions that you might have? Okay. Why was an MRI recommended by a neurologist if it's not as good as neuropsych testing? It scared my 90-year-old mom, and now she's distrustful of all medical community and won't go for neuropsych testing. And Aricept. So I will. So what happens with the MRI? So the neuropsych testing is best at identifying, say, the condition, the etiology, like Alzheimer's disease. But as part of your full workup. Like I said, that's why it's so important to have lab testing. Like, because we have to check, is your B12 low? In the same way in MRI, we have to check to make sure that there's not a brain tumor there. Right. So if we look at the MRI and we're like, oh, she's totally clear, there's no kind of cyst or tumor, a structural change that would impact her thinking, then we would go for the neuropsych testing, where then we can figure out this cognitive profile. So it's really recommended to have a full medical workup for this. Now, for your 90-year-old mom, for neuropsych testing, so the memory component of it is, our numbers aren't great for 90-year-olds. The most important part for a 90-year-old is safety. And so when we're taking that into consideration, we want to make sure that anything with a safety component is taken care of. So obviously, if there's a medical condition that's reversible, like a urinary tract infection, we want to make sure to treat that and have great quality of life. But if everything that can be resolved has been ruled out, then we just want to make sure that she is protected from a financial standpoint. You would be surprised the brightest people in the world can be swindled. From a medication management standpoint, mixing up medications is a surefire way to get yourself landed in the hospital, and then it's a crisis, and then you have people making decisions for you that you don't want them to make decisions for you. Okay, and then there was a question about Aricept. So Aricept is a treatment for Alzheimer's disease. So what it does is there's a chemical that the longer it's in the synapse, when you're doing neurotransmission, when you're talking about the chemicals in the brain, it leaves that chemical in there for longer. And Aricept helps that, and this chemical helps to consolidate memories. So Aricept, what it does is it slows down the loss of that chemical. It does not reverse anything. It just slows down that loss. So it's hard to say if it's being effective because it's just slowing down the loss of that chemical. Personally, it's such a benign medication. I have a friend who's a dermatologist, and please take this as a very joking, tongue-in-cheek way, but we joke around like everybody at 65 should be given this pack of pills that contains all these good things that for you, like that you're losing as you age. And we always joke around that Aricept should be in there because it's just one of those chemicals that you lose, and Aricept helps maintain that chemical over time. If you can, and start low and go slow, if you can tolerate the Aricept and it's recommended for you or a loved one, it's a good option. Obviously, again, I don't prescribe. Talk to your medical provider about it, and can really help because it's most effective when that memory loss is in its early stages. Okay, the next one is when someone has many ECT treatments, memory is affected. Any suggestions? So memory can be negatively impacted with the ECT. However, so there's a pro and a con with it, right? So ECT is one of those treatments is because you were resistant to other treatments and something had to be done because the depression was giving you no quality of life. And so by having the ECT, hopefully the pro for it is that you've had benefits to your depressive symptoms. The con to it is that it can negatively impact your memory. However, there are lots of amazing things that you can do for your memory that can help you with some of that memory loss. So there is a book, it's put out by Harvard. It's called Achieving Optimal Memory. You don't need to read the whole thing. Just read chapter 10. Chapter 10 of Achieving Optimal Memory has some really great everyday common sense type of things that you can do. So usually what happens is when people have memory changes, they keep doing whatever their external structure was before they had the memory changes. So maybe you were the type of person who never took notes. And so now you've had memory changes and you're like, I can't remember anything. But if you just took more comprehensive notes, you would rely on those more. So I am somebody who relies completely on a calendar. If it's not on my calendar, it's like it does not exist. However, my husband, this was pre our kids getting into travel sports, he never used a calendar. He kept everything right on his desktop in his working memory, and he was totally fine. Now, if he had had, let's say, a traumatic brain injury, and he would go back to thinking he could just do everything on the desktop in his head, and he would fail. But if he just utilized a calendar, he would succeed. And so there's some very simple organizational strategies that keeps your memory intact. I had and I'll go quickly. I was at Loyola, and we'd see a lot of the priests and nuns, and we had this nun, and she was well into her 90s, and I was like, how is she so independent? Her memory, there was nothing left. Memory was totally done. But she had a strategy for everything. She had her glasses case, safety pin to her waistband. She had a place for everything. Her external strategies were so perf perfect that she could be as independent as possible without ever having a memory. So there's lots of things that you can do. There is people who specialize in this. Cognitive rehabilitation therapists specialize in making these behavioral changes to optimize your thinking processes, and can really help. And not a long therapy process. We're not talking weeks upon weeks. 8 weeks, once a week, and you should have some good momentum in that area. Okay. If you have, oops, sorry, if you have a family history of your mother who had Alzheimer's and you had a beta amyloid 42/40 ratio test with results indicating intermediate risk, currently not having memory changes, is it appropriate to get a baseline assessment for preventative treatment? So it depends on your age, and the age of onset of your mother. So here's a little wink, wink, nudge, nudge. Insurance companies will not pay for baseline testing. So if you go in and say, I want baseline testing, you will have to pay for it out of pocket. So my recommendation is, if you would like to have baseline testing, which is not a bad idea if you have multiple risk factors, you have to present with at least one symptom. If you complain about one cognitive symptom, then it's covered by insurance. If you say baseline testing, it's a no-go. So if you're at the point where you're not having significant changes, but want to just get things checked out so that you can have a reference point for later down the road, it's a good idea. They do in Japan, they do it. They have obviously a different medical system, and they do baseline testing there. So people do have reference points. It is not done because of our insurance system here. So certainly if you're concerned and you'd like to do that, but again, always be truthful with your medical provider, but definitely have at least one symptom for insurance coverage. It says, do you recommend vagal nerve stimulation for severe depression? So I am not an expert in this area, so it's outside of my purview. So when I was at Loyola a million years ago, I was on the neurosurgery team, and Dr. Anderson loved exploring this area, and was very keen on some of the positive uh, outcomes that came from this type of stimulation. I think that there is some real merit to it. I think that there are sub-profiles of depression that it really helps. What we have not done a good job in our medical community is identifying what those sub-profiles are. But again, it's been some time since I've really delved into that in any kind of serious way. So it's definitely something that you can reach out to a provider who has that expertise to say, hey, is this a right move for me? So there's some promising initial research that was going on. And I'm sure there has been a significant progress since I delved into it. This one is, I recently had a CT scan of eye orbits, and the results mention age-related volume loss from a partial view of the brain. Does this mean anything significant? I am 83 and very efficient cognitively. So I do not think so. So we lose volume as we age. It is, I'm not an expert. The eyes are so complex. If you read that third slide or whatever I had with the caveats that had all the wires going everywhere, that is like the eye. The eye is so complex. If you are efficient cognitively and have some volume loss in the eyes, I would not worry about that at all. Here is something though, kind of related. I'm going to go off on a tangent here. So the olfactory bulbs are right next to the medial temporal lobe, and the medial temporal lobe is where you consolidate new memories. And there's this, and so neurologists have been into the smell test for a long time. It's a down and dirty, and if you're losing your sense of smell, it indicates a decrease in volume in those medial parts of the brain. So this medial part of the temporal lobe next to the olfactory bulb, and they kind of are losing volume. And there's this new research that's just out, and they've been using a diffuser, and they use a different scent each night because you can go nose blind, but it's using the different scent each night improves your memory because it's stimulating that area of the brain, that olfactory bulb, which is right next to the areas that consolidate memory. So I know that you were asking about eye orbits, and I went a total tangent to the olfactory bulb, but maybe get some good smelling candles and different one each night. It's supposed to, maybe not candles, that's dangerous. Do a diffuser. Go to Bath and Body Works. They have tons of them there. So, but very kind of interesting stuff. But I wouldn't worry about too much about incidental finding on a CT scan. CT scans are really great at detecting blood and not great at detecting much else. Okay, another question. Can neurological decline, dementia, Alzheimer's, affect things like visual perception of color? Also, how can you tell if withdrawal from beloved activities, reading, knitting, in the elderly is a function of dementia or treatable depression? Okay, so the visual perception of color does not have a correlation to Alzheimer's disease. It is not part of what we use in our assessment of visual spatial skills for when we're looking at things as a neuropsychologist. So I don't know that the perception of color is linked to cognitive decline. Probably because there's, like I said, the eye is so complex, and that would be that part of that perception is probably related to eye function, which is different from brain function. All connected, but different. So that loss of color, the perception of color, I wouldn't worry about it from a brain function standpoint. Okay, so withdraw from beloved activities. Is it dementia or is it depression? Great question, because a lot of people present initially with symptoms of depression prior to symptoms of dementia. And a lot of that comes along with, at that point, the person still has awareness and they're aware that their skills or abilities are declining, and nobody wants that to happen, and it does create a depressive symptom. So back in the day, I was at a memory clinic, and they did not, it was very hard to get into. And so they would just straight from the get-go, if we were looking at something that looked like any kind of dementia or depressive symptoms, they would prescribe both Aricept and Lexapro Pro right from the get-go, which is not a great idea to start 2 different medications at the same time, but they were just knowing that the patient wouldn't get in for months and months more. They would start them at the same time. As far as neuropsych testing is concerned, it can delineate out if it is an actual neurocognitive disorder versus depression. That's one of the things that we can look at that etiology on and determine that. But they are not mutually exclusive. They both can be occurring. So so you can get it tested to figure that out. And it could be one, the other, or both. Sorry, I was trying to talk so fast so I could answer everybody's questions. So I hope I was clear and enunciated well for you all. I'm here and I'm happy to answer any questions, but thank you so much for providing me with this time. I hope you enjoyed the information, and I'm happy to answer any questions that pop up. I'm at Thompson Memory, so again, you can always reach out to the office if you have further questions. I'm happy to help out.
Thank you so much, Dr. Blodgett, for presenting us with this super important information and answering our participants' questions. I know I learned a lot from you tonight, so I really appreciate you taking the time to be with us.
You're very welcome. It was a pleasure.
Yeah, thank you so much. And to all of you who are still with us, if you did enjoy tonight's program, you can find more information about upcoming programs at our website at www.namiccns.org. Our next program is going to be held on December 6th from 7 o'clock to 8:30, where Bob Anthony will provide information on Rotary International's guided self-management toolkit. This is a new resource to empower the pediatric provider to directly and immediately manage all mild and moderate cases, such as anxiety, depression, ADHD, or disruptive behavior disorder. Once you log off, you will see a short survey that will allow us to better understand your comfort level with today's topic, as well as provide us with information that we need to raise money so that we can continue providing our programs for free of charge in the Cook County North Suburban area. We appreciate your presence tonight, and we look forward to seeing you again at a NAMI CCNS community webinar. Thank you, and please take care of yourself and each other, and we will see you next month. Bye. Thank you, Dr. Blodgett.
Thank you.
I will see you soon. Have a great night.
You too.
You did
Bye-bye.
wonderful.
Thanks.